Hello everyone. So I will talk about INI CET November 2024 question. So there were 7 questions which has come from anesthesia, and all the questions were which could be easily solved by after listening the video lectures of anesthesia on DocTutorials. So first question was on a supraglottic airway device, Ambu Aura 40. Now Ambu Aura 40, they have asked, this is what type of supraglottic airway device? First generation, second generation, third generation, or fourth generation? Now this is kind of direct question which has been picked up from last year INI CET, the June INI CET, where they asked a question on supraglottic airway device with Ambu Aura as one of the option in the question, right? The last exam which they asked, the question was that which of the following is second generation supraglottic airway device? And in the options were ProSeal LMA, classical LMA, Ambu Aura, and intubating LMA. So the answer was ProSeal LMA, which is the second generation supraglottic airway device. So classical LMA and Ambu Aura was first generation, and intubating LMA does not have any generation. So that was the question asked last year. So the same, the similar kind of question was formed this year also. They asked Ambu Aura gain is what? So why Ambu Aura gain is first generation supraglottic airway device. So we should know the difference between the first generation and the second generation supraglottic airway device. So this is an image of Ambu Aura. Guys, Ambu Aura is first generation. Why do we call it first generation? First generation supraglottic airway device does not have a gastric channel. They only have the airway channel. They have only airway channel. So they don't have a gastric channel. They have a mask which is attached to the airway channel, and the mask is inflated, which forms a seal over the glottic opening. And the seal is not strong enough in first generation devices to prevent aspiration. So let us discuss the difference between the first generation supraglottic airway device and the second generation supraglottic airway device. Now first generation, the prototype device of this is classical LMA, which was designed by Dr. Archie Brain. And Dr. Brain noticed that classical LMA was not preventing aspiration. So he evolved with the device and came up with second generation, and the prototype is ProSeal LMA. Okay, so what is the difference? The first generation supraglottic airway device only have a single sealing, let's say cuff. They have a single tube for ventilation, and they have one work, that is as a rescue airway device in difficult airway situation. So they have one tube. This is used for ventilation. This is the airway tube. They have one opening, which is the distal opening for ventilation, and it has one cuff to create a seal over the glottic opening. And the major demerit that this device cannot prevent aspiration. This device cannot prevent aspiration. Okay, so this device had to be improved, and therefore the second generation came. And second generation has everything too. It has two tubes side by side. One is the airway tube and the other is the gastric tube. Okay, then it has two cuffs and it has two openings, one for the airway ventilation, other for insertion of Ryle's tube through the gastric tube, right? So it has two openings. One opening is on the tip of the device as well. And this device is comparable to ET tube in preventing aspiration. So comparable to endotracheal tube in preventing aspiration. Okay, so this is the difference between first and second generation supraglottic airway devices. I'll show you images of few devices because questions are very commonly being asked. So classification, first we need to discuss the names and then I will show you the images. So first generation supraglottic airway device, they are simple airway tubes. I said they have only one tube for ventilation. And what are the devices which comes under it? The classical LMA is the prototype device. Okay, the laryngeal mask airway, the classical LMA, the flexible LMA, which is the same classical LMA, but the tube is flexible because of reinforced wire on the inner circumference. Then unique LMA, that is unique LMA. Then cobra perilaryngeal airway and ambu aura 40. They all come under the first generation. Now coming on the second generation, which added a gastric tube or drainage tube. The prototype is ProSeal LMA, the iGel airway, the LMS Supreme, the SLIPA, the streamlined liner pharyngeal airway. And Ambu company has come up with the second generation also, that is Ambu Aura Gain. So Ambu Aura Gain, when Gain was added, it is second generation. Ambu Aura 40 is the first generation. Like classical LMA is first generation, ProSeal LMA is second generation. I'll show you the images of some of the devices. So you can see the first generation, they all have a single tube. They all have a single tube. So this is your classical LMA, right? It has a mask, it has a tube, right? This is your LMA. This is your flexible LMA, right? Flexible LMA. Then this is your cobra perilaryngeal airway device, cobra perilaryngeal device, right? So, and this is also flexible LMA, flexible LMA. Okay, so these all are first generation. So second generation, you can see the each device has two tubes. This is the airway tube, this is the gastric tube, right? This is ProSeal LMA, ProSeal LMA. Now, this is your LMA Supreme, right? This is your iGel airway, iGel airway. So these three devices are important, iGel airway. Okay, so this is iGel airway. Okay, so these are second generation with extra a gastric channel added to it. Okay, so this is first and second generation that we have to remember. Now, third generation, third generation is still not very acceptable term, but yes, if a question is asked on third generation, then one device we can keep in as an answer is Buska device, Buska airway device. So this is third generation supraglottic airway device, third generation supraglottic airway device, right? This is your Buska mask. It is called BASK, Buska mask. So what is unique about this third generation device? It has an airway tube and it has two gastric channels, right? Second generation has two tubes, one airway, one gastric channel, and the third generation has three tubes. Okay, so this is creating a superior gastric reflux suction clearance, and it produces a much better seal for positive pressure ventilation, right? So this is third generation Buska mask, we call it, right? So this is all about the first question. The answer is that Ambu Aura 40 is first generation, and guys, Ambu Aura Gain, the same company has come up with second generation also. So when the Gain is there, Ambu Aura Gain, it is second generation, and Ambu Aura 40 is first generation. All right. Okay, so next question. Next question, again a very simple question on the drug, right? On a very important IV induction agent, very frequently asked in exam, etomidate. So they asked this question, which medication can cause adrenal suppression? So number of times in my class, offline, online, I taught you that etomidate has two star points. One black star point, which is a bad point, and one red star point, which is a good point of etomidate. The black star point is that it inhibits the adrenal gland. It inhibits the adrenal gland. It causes adrenal suppression. So it inhibits cortisol synthesis. So cortisol synthesis is inhibited. Okay. So this is about our etomidate black point, and that's why it is not so frequently in clinical use. What is the red point of etomidate? The red point is, this is the only non-opioid IV anesthetic agent which is completely cardiovascular stable. Cardiovascular stable. Okay. So question was, which medication can cause adrenal suppression? So etomidate can cause adrenal suppression. This should be the answer. Now let us discuss few important point about etomidate. Etomidate, which is a IV induction agent, IV induction agent. Now, etomidate is a imidazolone derivative. It is imidazolone derivative. Okay, and this drug, the dose of the drug for induction is your 0.3 milligram per kg body weight. Okay, the metabolism of the drug is by liver and kidney. Liver and kidney. Now, this drug comes in two preparation. One is the lipid soluble milky white preparation and other is a transparent preparation. So, it comes in the two preparation, right? One preparation is milky white, right? And the other one is transparent aqueous preparation. Okay, so the transparent aqueous preparation can cause pain on IV injection. Pain on IV injection. So it can also cause pain on IV injection. That's why the lipid soluble milky white preparation came into existence to decrease this pain on IV injection. But there are some typical side effects which we need to know about etomidate. The typical side effects of etomidate. First and foremost, the most important side effect, adrenal gland suppression. So it can cause adrenal gland suppression. So this is the most important point of etomidate. Second, it can cause myoclonus, right? So myoclonus can be precipitated by etomidate. Then third, it is highly emetogenic. So highly emetogenic. So this drug is highly emetogenic. Okay, so these three important side effects we have to keep in mind for solving the questions. The best point of etomidate is it is completely cardiovascular stable, and because of this best point, it is agent of choice in patient with the cardiac dysfunction, right? So this is anesthetic agent of choice in patient with cardiac dysfunction. Okay, so this is all I want to tell you about etomidate. If we see the options, then we have succinylcholine. Now, the most important side effect of succinylcholine, which can be asked in exam, is your hyperkalemia and bradycardia. Hyperkalemia and bradycardia. And a very important point of succinylcholine, it can trigger malignant hyperthermia. Okay, then propofol, the most important side effect which we need to know is pain on injection. Pain on injection, right? So propofol can cause pain on injection. And ketamine, the most important side effect which we need to know is emergence delirium. So many times question has been asked on it. Emergence delirium. Okay, so this is our second question. Answer is etomidate. Now coming on the third question, a patient with a fractured rib from 1st to 5th required analgesia. So which should be preferred? So option was supraclavicular block, cervical plexus block, lumbar epidural, thoracic epidural. Now guys, supraclavicular block is used for upper limb surgery. It is used for upper limb surgery. Now it is called spinal anesthesia of upper limb because most of the surgeries of upper limb can be performed under supraclavicular block. So this is also called sometimes spinal anesthesia of upper limb. Okay, because all the surgeries of upper limb can be performed under supraclavicular block, but it is limited to the upper limb surgery. The cervical plexus block, superficial and deep cervical plexus block is not practiced. Superficial cervical plexus block, in this, thyroid surgeries are mostly done. Right? Then lumbar epidural is mostly used for abdominal surgery. Right? It's used for providing analgesia for abdominal surgery. Thoracic epidural is indicated for the thoracic surgeries, for provide analgesia for rib fracture. So thoracic epidural is for thoracic surgery, and it is also used for providing analgesia in rib fracture. Kind of, this is the for rib fracture analgesia, this is one of the most common mode of analgesia to provide analgesia. Okay, so if we talk about the rib fracture post trauma, then what are the ways of analgesia for analgesia after rib fracture? The gold standard is thoracic epidural. Okay, Now there are several other blocks also which we can practice. One of the common block used for rib fracture surgery is erector spinae. Erector spinae plain block, right? Erector spinae plain block. Then we can use serratus anterior plain block. Serratus anterior plain block, right? Okay. We can, so these are the blocks which can be used in alternative to thoracic epidural. But thoracic epidural is considered gold standard for the analgesia to be provided for the fracture. Okay, so remember this. Now remember guys, epidural is one of the very common technique to provide analgesia, and depending upon where the level of analgesia required, we put the epidural catheter there only. So epidural can be used, can be inserted as thoracic epidural, as lumbar epidural, and as sacral epidural. Now sacral epidural, which is also has another name, that's called caudal anesthesia. Caudal anesthesia. Okay. So let us talk about thoracic epidural. Thoracic epidural is most commonly used for your thoracic surgeries, for rib fracture, right, for rib fracture, and upper abdominal surgery, okay. Your lumbar epidural is used with GA for providing analgesia or as a sole technique for abdominal surgeries, mostly for abdominal surgeries, like. And lumbar epidural is also used apart from abdominal surgery for labor analgesia to provide pain relief during labor. Sacral epidural is one of the commonest technique to provide post-op analgesia in pediatric patient for lower abdominal and urological surgeries. So this is most common technique for post-operative analgesia in pediatric. Post-operative analgesia in pediatric patient, okay. So pediatric patient, caudal is what we are practicing, easy to go in less than 7 years of age. So this is the most common technique for post-op analgesia, okay. So answer for rib fracture was the thoracic epidural, okay. Now coming on the fourth question. The fourth question was again from a very expected topic, resuscitation. So what is true about resuscitation in children? We have talked so many times about resuscitation. The first option is adrenaline is given in 0.01 milligram per kg, 1 in 1000 concentration. Now this statement seems incorrect because 1 in 1000 concentration is never used through IV injection. It is always 1 in 10,000. Chest compression should be 1/3 of the AP diameter. Now this is the right statement. Whether it is adult or pediatric or infant, the chest compression depth should be 1/3 of the AP diameter. So this is the correct statement. But let us see the other statement. Compression ventilation ratio is 30:2 in presence of 2 rescuer. Well, it is 15:2 in the presence of 2 rescuer. 30:2 is in presence of 1 rescuer. Adenosine should always be administered interosseous. Guys, interosseous route is the second route if we are not able to have a IV route. So it always has to be administered intravenously. If for some reason I'm not getting IV route, then only I can go for alternative routes. And interosseous is if we are not getting an IV cannula for in cardiac arrest patient, then we go for interosseous route. Okay. Okay. And adenosine is, drug of choice for managing paroxysmal supraventricular tachycardia. Right? This is not a cardiac arrest. So definitely we will secure an IV line and then we will give the adenosine. Okay. So let's talk a little bit about the resuscitation in the pediatric patient, the basic life support and the advanced cardiac life support. Two things we need to discuss. We will also discuss along with it the difference between children and infant. So what is infant? Infant is less than 1 year excluding newborn. So excluding newborn. Children is 1 year to puberty. And adult is puberty onwards. Okay. So there are some gross differences in resuscitation between these three age groups, which we will discuss. So let us first see the flow chart of pediatric and infant BLS. So like any other basic life support, whenever we have victim who seems unresponsive, the first thing which we do is scene safety. So scene safety is first thing. After scene safety, we call for help. So we call the emergency response. After this, we check the breathing and the pulse of the patient simultaneously. If both are present, then we put the victim in recovery position and wait for the ambulance to come. We have to investigate why the victim is unconscious. If patient has no breathing but has a pulse, then this is respiratory arrest. And in this case, we just give the rescue breath. In children, we give one breath every 3 to 5 minutes. That is 20 to 30 breath in a minute, right? So one in every 3 to 5 minutes, right? And if when I am giving the breath one in every 3 to 5 minutes, the pulse rate of the patient is not improving. Pulse rate remains less than 60. Pulse is there. We count the pulse in children also, unlike adult. Now, if the pulse rate is not improving, then we will add the chest compression as well. So, if we add chest compression, if pulse remains below 60 and there are signs of poor perfusion, okay. Now, both are absent, no pulse, no breathing, then this is cardiac arrest. And in cardiac arrest, if we have witnessed the collapse, right, it's a witnessed cardiac arrest, right. So, what do? If it's a witnessed cardiac arrest, if we have not informed the emergency, we activate the emergency and then start with resuscitation. If it is unwitnessed, we start with the resuscitation immediately. If one rescuer is there, we begin the cycle of 30 compression, 2 ventilation. If more than one is there, 15:2, right? Then after every 2 minutes, we check for the pulse and we again continue doing the compression ventilation if there is no pulse. As soon as the AED comes, we attach the AED. AED recognize the rhythm, whether it's shockable or non-shockable. If the rhythm is shockable, we give the shock and we resume compression ventilation. If the rhythm is non-shockable, we resume compression ventilation. We don't give shock. We go on doing this till the victim is resuscitated successfully, victim starts moving, or the ACLS team takes over. So what is the major difference which we just now discussed in the pediatric BLS and infant BLS from adult? Now I would just go in the sequence. The pulse which we feel in adult is always carotid. In children, it is carotid or femoral. And infant, it is brachial, always brachial. Then the compression ventilation ratio. In adult, it is always 30:2, irrespective of number of rescuer. In child and infant, it is 30:2 if we have one rescuer and 15:2 if we have more than one rescuer. Got it? Okay. Then depth of compression. Depth of compression. In adult, it is at least 5 centimeter. We keep it between 5 to 6 centimeter. Children, about 5 centimeter. Infant, about 4 centimeter. Okay. This is the depth of compression. The respiratory rate, if I am giving the rescue breath, in adult, it is 10 breath per minute. In children and infant, it is 20 to 30 breath per minute, the rescue breath, if I am giving in respiratory arrest. These are the major differences in case of your BLS management. Now let us see the management of ACLS in children. Now ACLS management, so many times we have discussed, it is done after attaching the ECG electrode. The management depends upon the type of rhythm in the cardiac arrest. So there is two type of rhythm possible in cardiac arrest: shockable, non-shockable. So if the rhythm is shockable, we give, that is, it is either ventricular fibrillation or pulseless ventricular tachyarrhythmia. We give a shock immediately. Then again we do CPR for 2 minutes. We take a IV IO axis, and if, let's say, the rhythm after 2 minutes, we check the rhythm. If it is still shockable rhythm, we give the shock. Again we continue doing CPR for 2 minutes and start giving the emergency drug. The emergency drugs are same as the emergency drugs in adult. Epinephrine first, followed by amiodarone. Epinephrine we give every 3 to 5 minutes. So what is the dose of epinephrine used in pediatric? It is IV or IO dose 0.01 milligram per kg body weight, 0.1 ml per kg, that is 0.1 milligram per ml concentration. So 0.1 milligram per ml concentration mean 1 in 10,000, right? 1 milligram in per ml concentration means 1 in 1,000. 0.1 milligram per ml concentration means 1 in 10,000. Always for resuscitation, when we are giving adrenaline IV, it has to be given in 1 in 10,000. So 1 in 10,000 concentration we have to give, and we repeat every 3 to 5 minutes. Okay. Amiodarone is the next drug which we can give. The dose is 5 milligram per kg body weight bolus. If amiodarone is not available, we can give maximum 3 doses. If it is not available, we can use lidocaine. 1 milligram per kg is the dose. Okay. So we start giving the emergency drug. Rhythm is shockable. Every 2 minutes we give the shock. We do CPR for 2 minutes. We check the rhythm and we manage accordingly. If it's shockable rhythm, we give the shock and we go on giving the emergency drugs. Adrenaline every 3 to 5 minutes. Amiodarone only 3 doses in pediatric. In adult, we give amiodarone in 2 doses, 300 and 150. In pediatric, we can give 3 doses. 5 milligram per kg body weight of all the 3 doses. Okay. So this we have to remember. This is the management of shockable rhythm. Now non-shockable rhythm, we do CPR, that is asystole and pulseless electrical activity. We do CPR and we start giving the emergency drug as soon as possible, ASAP. That is epinephrine and nothing else. CPR and epinephrine, CPR and epinephrine. So this is what is the management of non-shockable rhythm, and we try to find the reversible cause and try to treat the reversible cause. So what differences we discussed from in ACLS in adult and pediatric, right? The first difference which we need to know is the shock energy in shockable rhythm. In adult, we are starting with between 120 to 200 joules, right, of the biphasic shock. In pediatric, it is 2 joules per kg body weight. And we go on increasing to 2 joules. Like next shock, 4 joules per kg body weight. Next shock, 6 joules per kg body weight. This is how we increase it. So shock, first difference is shock energy. Then the dose of adrenaline. In adult, it is 1 milligram, 1 in 10,000. Okay. In pediatric, it is 0.01 milligram per kg body weight, 1 in 10,000. Right. So this was the incorrect thing which is given. As you can see here, it is 0.01 milligram per kg body weight. Okay, so we give 0.01 milligram per kg body weight, 1 in 10,000. And in the question, it was 0.01 milligram per kg body weight, 1 in 1,000 given in the option, which was incorrect. Okay, then the dose of amiodarone, right? The dose of amiodarone in adult, it is 300 milligram first dose, and the second dose 150 milligram as the second dose. In pediatric, right, we can give 3 doses. The first dose and the second dose and the third dose same, 5 milligram per kg body weight. Got it? So this is the major differences between adult and pediatric ACLS. And in both rest of the things are similar. We do the CPR. We try to treat the reversible causes of cardiac arrest. So this is about the question on the cardiac arrest. So answer is, the right statement is chest compression should be 1/3 of the anteroposterior diameter of the chest. Okay, coming on the fifth question. So fifth question was again a very simple question on the circuit, anesthesia breathing circuit. They gave the Jackson-Rees circuit is used for, well, this is the most popular Mapleson circuit, Mapleson D, used in pediatric patient. So answer is pediatric anesthesia. Well, what is Jackson-Rees circuit? This is the diagram of Jackson-Rees circuit. Now this is also called Mapleson F. Mapleson F circuit, right? And this is the only pediatric circuit we use, only Mapleson circuit used in pediatric patient. So guys, we have 6 Mapleson circuit. We have 6 Mapleson circuit A, B, C, D, E and F, right? A, B, C, D is used in adult. E and F is used in pediatric, right? E and F is used in pediatric. Now, Mapleson E, the first pediatric circuit, that's also called IR's TPs, right? IR's TPs. If you see this Mapleson F circuit, if I cut it here, it becomes IR's TPs. When we attach this bag with the opening on its other end, then it becomes Mapleson F circuit. So Mapleson F circuit is modified Mapleson E, and who modified it? Jackson-Rees. So it is also called Jackson-Rees circuit. So this is modified Mapleson E, or we call it Jackson-Rees circuit. Jackson-Rees circuit. Who modified it? So these both are pediatric. Now this IR's TPs, this is bagless, valveless are not commonly used. Bagless and valveless. And its modified version, that is modified Mapleson E is Mapleson F, Jackson-Rees circuit is the most common pediatric circuit. This is most common pediatric circuit, right? Most common pediatric circuit used, right? For both spontaneous and controlled ventilation. So in pediatric, it is Jackson-Rees circuit. In adult, we have 4 options. A, which is also called Magill circuit, and this is the circuit of choice for spontaneous ventilation, and D, that is your Baines circuit is circuit of choice for controlled ventilation, circuit of choice for controlled ventilation, remember this, okay? So these things we need to remember in Mapleson circuits. So remember, Jackson-Rees is the circuit which is most commonly used in pediatric patient, okay? So this was our 5th question. Now coming on the 6th question. 6th question is again on IV induction agent, Thiopentone. Incorrect statement about Thiopentone. It is lipid soluble. All anesthetic agent has to act on brain, so they have to be lipid soluble. So it's the right statement. Maximally excreted through kidney. Well, metabolism is liver and dependent upon liver and kidney. It is not excreted through the kidney without getting metabolized. So it's liver metabolism and then the metabolite is excreted through kidney. Redistribution is seen, which is a right statement. All IV anesthetic agent undergo redistribution. Achieves maximal brain concentration by IV route. Well, this is a self-right statement. Any drug will achieve maximum concentration through IV route only. So which seems the wrong statement? The B seems the wrong statement. So remember guys, that 4 important non-opioid IV anesthetic agent, thiopentone, propofol, right, etomidate and ketamine. Okay, now these drugs, they are used as, that's a diverse group, non-opioid. They all can be used as IV induction agent, right? And when we give them, thiopentone has fastest onset of action within 1 brain arm circulation, That is, within 11 to 14 seconds, the patient becomes unconscious. Rest also mostly within 30 to 90 seconds, right? The single dose of all the 4 drugs is duration of action is only for 6 to 8 minutes because all of them show a property called redistribution, right? So redistribution is seen in all the 4 drugs. That is, they get detached from the receptor in the brain and get redistributed to other organs like fat, muscle, etc. So all of them show the redistribution. So by redistribution, patient regains the consciousness. Okay, metabolism of all the drug. Thiopentone, liver and kidney, hepatic and kidney, right? metabolized in liver, excreted through kidney. Propofol also hepatic and kidney. Etomidate also hepatic and kidney. Ketamine also hepatic and kidney. Only propofol also has a extra hepatic, extra renal route of metabolism. So, extra hepatic and extra renal route also. So, it has extra hepatic, extra renal route of metabolism also, right? Otherwise, mostly by liver and kidney, 80%, 20% by extra hepatic, extra renal route of metabolism. Now, let us talk a little bit about the uses of thiopentone. Now, thiopentone has somehow become obsolete for anesthesia. For anesthesia, it has been completely replaced by propofol. But there are two places where still it is drug of choice. So, thiopentone is drug of choice in narcoanalysis, that is lie detection test, and for neuroprotection. So, it is drug of choice for narcoanalysis and for neuroprotection. So, two places thiopentone is drug of choice. Okay, it is the best drug to offer cerebral protection or neuroprotection because it decreases the CMRO2, cerebral metabolic oxygen requirement, by 55 to 60%. Maximum a drug can reduce. So, it has the capability of highest brain protection among all the drugs. So, this is about thiopentone. Okay, it is a sulfur containing yellowish powder. Before giving it, we mix with it either normal saline or dextrose to make it in a liquid formulation. And shelf-life of the drug after making it in the liquid is 7 days. So, it comes in yellowish powder, and when we prepare it, then the shelf-life, it can be used for 1 week only. Okay. Now, so this was our 6th question. The answer is, the incorrect statement is maximally excreted through kidney. Both liver, hepatic and renal route is responsible for its metabolism. Okay. Now, coming on the 7th question. 7th question, the exact option I haven't got. The question was asked on the ERAS protocol. ERAS is the enhanced recovery after surgery. Enhanced recovery after surgery. So, since I didn't get the proper options for the question, I have formulated my own question on ERAS. The answer of this question was most probably that prolonged fasting is not recommended in ERAS. Yes, prolonged fasting is not recommended in ERAS. So, what for ERAS, that is enhanced recovery after surgery, we practice some preoperative techniques, some intraoperative techniques, and some postoperative techniques, so that the recovery in the patient is fast. So, what are the what question first I made? I made this question: what statement is true about ERAS protocol? Avoidance of prolonged postoperative fasting. Fluid should be given leisurely. Good pain control with opioids. Postoperative feeding should be delayed. So, I will come back on this question. So, preoperative strategies for ERAS, enhanced recovery after surgery. We need to identify and optimize all the comorbid condition of the patient, right? Prehabilitation, like cessation of smoking, the spirometry, etc. should be encouraged in the patient in pre-op period. Then patients and family education and the discharge plan, everything should be made in pre-op period. Avoidance of prolonged pre-op fasting. So the guideline says till 2 hours prior to surgery, patient should be allowed to take the plain water. So we have to strictly follow it for a enhanced recovery. Then pain management planning should be done, and pain management planning should be in such a way that opioid should be used minimally, because opioid has a lot of side effects, like especially nausea and vomiting, which can delay the discharge. So we can go for multiple drugs in pain management. We go for multimodal analgesia technique. Then for selected procedures, we can go for thromboembolic prophylaxis also, right, with subcutaneous heparin. Apart from this, there are some intraoperative strategies also. The minimal invasive surgical approach should be used. Laparoscopic surgery, robotic surgery, they give a better recovery, faster recovery. Antibiotic prophylaxis should be given 30 to 60 minutes prior to the surgical incision to prevent any infection. Use ultra-short acting anesthetic agents for inhalational or IV during induction and maintenance of anesthesia. Now, ultra-short acting, that is which goes out of the body very quickly. So, among inhalational, we would use desflurane, or sevoflurane. And among IV, we would use propofol, right? And in opioid, we will use remifentanil. Avoidance of the fluid overload. If you give fluid overload, the recovery becomes slow. Complications can happen. Lung protective mechanical ventilation should be practiced. Maintenance of normothermia. Hypothermia can cause the admission of the patient as an inpatient for further management. So maintenance of normothermia. Good glycemic control. Multimodal antiemetic prophylaxis. The most common reason, especially in ambulatory surgery for admission, is nausea and vomiting. So we need to go for multiple drugs as antiemetic prophylaxis. Procedure-specific multimodal opioid sparing the pain prophylaxis. So these are intra-op strategies. Coming on post-op strategy. Rescue therapy for nausea and vomiting. If in spite of prophylaxis patient is complaining nausea, vomiting, we can give the rescue drugs. Then procedure-specific opioid sparing pain management. Oral feeding should be started in post-op period as ASAP, as soon as possible. Early post-operative mobilization and physical therapy, right? You can move the patient, you can mobilize the patient as soon as possible. So these are the strategies for enhanced recovery after surgery. So coming back on the question, avoidance of prolonged preoperative fasting. Yes, this is true as the preoperative strategy for ERAS. Fluid should be given leisurely. No. Fluid restriction should be practiced, right? Over hydration can lead to a lot of complication. Good pain control with opioids. Opioid sparing techniques should be used. Post-operative feeding should be delayed. Post-operative feeding should be started ASAP, as soon as possible. So which is true? Avoidance of prolonged preoperative fasting. So these are the protocol for ERAS which we need to remember. The strategies, the pre-op, the intra-op and the post-op. So these were the questions which was asked in the exam. So let us just revise all the answers very quickly. So which statement is true about the ERAS protocol? Avoidance of prolonged preoperative fasting. Incorrect statement about thiopentone, maximally excreted through kidney. No, liver and kidney metabolism. Then the Jackson-Rees circuit is used for pediatric anesthesia. And then which is incorrect statement about resuscitation in children. Which is true about resuscitation in children? Chest compression should be 1/3 of the anteroposterior diameter of the chest. Then patient with fractured ribs from 1st to 5th required analgesia, which should be preferred. Thoracic epidural would be the gold standard for controlling the pain. Then question on etomidate. Which medication causes adrenal suppression? Etomidate. That's the star question of etomidate. Then question on the supraglottic airway device. That Ambu Aura 40 is what? It is first generation supraglottic airway devices. So these were the 7 questions. Easily answered questions which are quite expected, and I know most of you must have answered 100%. Best of luck for your result. Thank you.